All right. So this week's lecture is going to start in chapter 37 in your book. And if you're in your book, you can see we're getting close to the end. So not not much longer for this. This is the last big section, trauma. So once we get through trauma, we've got two small sections to get through, which will finish us off, and that's probably going to be about middle April time frame, and then the last 2 or 3 weeks of the class is going to be reviewing and TSOPs and final exam stuff. So um, coming quick towards the end, we're going to be wrapping up a lot of things here in quick fashion. But getting through this trauma section is the last really big bite of the course. So a couple more weeks of trauma, and then you'll be looking at the module exam for that, and we'll have two little small modules afterwards. So this week, three chapters in your book. We're doing 37, 38, and 39. And again, that's chapter 37 is going to be the head, face, neck area. 38 is going to be the chest, and then 39 the abdomen. So we're going to be doing trauma stuff for these areas. What we're checking for, what we're looking for, what kinds of problems we're having, and then what we can do for these patients at the A level to help them out. So with the head, as we start this chapter, all the chapters in this book has a pretty standard thing with the anatomy and physiology. So it gives you a good little breakdown of the brain and the face, the skull, all the bones up there, and different things, and the eye uh, is also broken down for you again. We just talked about a whole bunch of eye injury type stuff in the end of the medical section, and they've got it all here for you again. So which is good for you. But as we deal with trauma patients, and we start our assessment of them, we're going to look for initial contact. We're going to check these patients for responsiveness. We're going to look for the ABCs, make sure all of that stuff is in place. We're going to check life threats. Um, and then once that has all happened, we're going to do a more detailed a look at these folks, a more detailed assessment where we're going to take that systematic approach, and the system kind of changes person to person, but typically we start at the head and work our way down the whole entire body, where we're looking for things, we're doing some assessing, we're noting any problems that we find, any injuries that we find. So how somebody want to talk to me about how they're going to assess the head and what specifically you're going to be looking for.
DCAT, BTLS.
Okay, those are the things that we're looking for, DCAP, BTLS. So those types of injuries are what we're looking for. So at the head area, where would you be where would you be doing this, and what can you kind of walk me through how you would be doing this?
Basically, you could look for any kind of deformities anywhere on the head, really the back of the skull, front of the skull, top, any blunt force trauma.
Okay, so deformities in the skull would indicate a blunt force trauma injury. And then what kind of expectations will we start to think about this patient? What type of potential injuries?
Probably is some traumatic brain injuries, stuff like that.
Okay, so traumatic brain injury, certainly a possibility. if there's some kind of deformity in the skull. If we're talking about traumatic brain injury, what kind of presentation would we be on the lookout for?
Altered mental status.
Altered mental status, certainly one of them. What's some other signs of a traumatic brain injury?
Might be aggressive.
They could be aggressive.
Pupils responding differently.
Pupils responding
Mhm.
differently, so
Differently.
not equal.
One dilated, one constricted.
Yep. Unequal pupils would be an indication.
They won't be oriented.
Okay. So we've got an altered mental status, we've got unequal pupils, we've got aggression, disorientation. What else?
Dizzy, nauseous.
Dizzy, nauseous.
They could have some difficulty speaking.
Yep. What about
They
vital
could-
sign wise?
They're probably going to be, they
Elevated.
might,
So the blood pressure is probably going to be through the roof.
Okay, so hypertension. Why are they going to have hypertension?
Because of brain swelling.
And that's true. The brain is swelling.
And the body's trying to compensate for shock.
And how's it doing that?
Trying to raise the rate of perfusion.
vasoconstriction.
So this traumatic brain injury typically is going to cause brain swelling, and because the brain is in a confined space within the skull, when it swells, it really doesn't have anywhere to go, right? It's not like your head gets bigger like all the other parts of your body, right? If your foot swells up, it gets bigger. But if your brain swells, your head really doesn't get bigger. So, so what happens is intracranial pressure increases with this swelling. And because of that, your body is increasing blood pressure to overcome that increased ICP so that it can get perfusion to the brain. So you will see these people, typically these people are going to have high blood pressures if they have this brain swelling going on. In later stages, you will start to see some issues with you're going to see high blood pressures, but you're going to see low heart rates with these folks. And then as it progresses even more, you're going to see some abnormal breathing patterns. So, so none of your vital signs are going to be working together real well with these head injuries. You know, typically if we expect patients, if blood pressure increases, heart rate is increasing, um, respiratory rate is increasing, a lot of these things go up together. And then if you have shock symptoms, you know, heart rate's increasing, respiratory rate is increasing, but blood pressure is kind of normal. So that's compensated shock. And then when you start to decompensate, then those things start, the rest of them start to go down as well. So blood pressure is going to be going down. Um, Initially, heart rate will be up, blood pressure starts to drop, and when it can't keep up, then they all go down. So with this ICP issue from these traumatic brain injuries, initially you're going to see a really high blood pressure, and as this thing continues to swell, this brain eventually is going to herniate if there's no relief given, and you'll start to see the rest of the vital signs are going to get real wonky on you, because you'll see a really low heart rate into like a bradycardic area with a really high blood pressure and then some abnormal breathing patterns. So you know you've got some real issues at that point. But um, ICP is going to cause all of these things because that brain is swelling. So what do we do for these folks? How do we relieve that swelling and that pressure?
Get them to a higher level of care.
Okay. That's it. The fix for it is to drill a hole and relieve the pressure. So that's what the neurosurgeons are going to do. If they can't use some medications to relieve that pressure, then they're going to drill a hole in the skull to relieve the pressure and allow room for that swelling until it can stop and reverse. But if there's no relief given, then that brain is going to, if it continues to swell, it's going to herniate. And where is it going? Where is the out for it?
Enter through the orbital lobes or orbital sockets.
Potentially there. And where's the bigger opening though?
The base of the skull.
Yep. Down where the brain stem heads down the spinal column. So that's the bigger opening, and most likely where the brain is going to herniate. So you'll see that in these folks. At that point, when that happens, you're going to see some actions from these folks that's going to be pretty dramatic. You may get into seizures at that point, or some type of posturing. The altered mental status may go to a point where they're not responsive anymore, and this injury is really progressing to the point of not recovering. So so if you get these folks head injuries, if they're alert and oriented to begin with, and all of a sudden you've got nausea and vomiting, you should suspect at a minimum like a concussion, but more likely this traumatic brain injury type of thing. So visualize your brain inside your skull, and when this blunt force impacts the skull, your brain kind of bounces around in there, you know, almost like a pinball. It bouncing around from side to side, banging off of the skull. There is a little bit of fluid in there for shock absorbing, but if the force is strong enough, it's going to overcome that, and your brain is actually going to impact the skull. Maybe once, maybe more, depending on the force. And so you're going to have these injuries. If there's any kind of external bleeding out of the brain into that space between the brain and the skull, that's going to impact the ICP pressures. If there's injury enough to the brain, it's going to swell. That's going to take up that space as well, which is going to shoot up those pressures. So these types of things are going to increase that pressure. And when you see those pressures change and increase, you're going to start to see these things in these patients. A lot of these signs and symptoms. Your book has a list of about a dozen of them. If you're in your book on 853, there's a list of about a dozen signs and symptoms for this traumatic brain injury and due to increased ICP. It's a big deal. Traumatic brain injury is getting a lot of attention now from various entities. The military is dealing with it from all of their folks that are, if they're in combat zones or even in training zones where there's explosions and concussions from the explosions. These folks are having to deal with these types of injuries. The NFL, the football players are dealing with this stuff, and there's a big push on that side because of those high impact tackles. They've increased technology with the helmets. They've changed the rules to try to protect these folks, but day after day, week after week, your brain being knocked around inside of your skull like a pinball, it's going to have some long-term effects, and so those folks, the football players, are experiencing that after 5 or 10 years of playing professional football. They're having memory loss issues, motor function issues. So, a lot of them, hands are shaking, having trouble feeding themselves and stuff like that. So, those fine motor skills are being negatively impacted. NASCAR is also on the move with this. All of their safety restraint systems that they have because of these injuries. So you guys locally could see like some high school football players that are getting knocked around, and they could be pushing some of these signs and symptoms on you. So be mindful of these things as you go. In the traumatic brain injury world, we can put them into the concussion diagnosis, a concussion protocol. That's changed over the last few years. The mindset of concussions and how to deal with them has changed. So if you're old and you heard concussion before, then you remember, don't let the people go to sleep. Keep them awake, keep them talking. If they go to sleep, they might not wake up. And that's completely changed and done a 180. So now, if they get diagnosed with concussions, the studies and technologies have taught us that the body heals when it rests, and so all the healing takes place when you're sleeping. So now, if you're given a concussion diagnosis, they're going to tell you to go to sleep. They're going to tell you to rest. So as much sleep as you can get and rest for a few days is what these people are going to be told to do. So things are changing with these head injuries, with the knowledge of what's going on, with the technology trying to prevent it. There's a whole training class now on football injuries and how to remove helmets and shoulder pads, and they've got techniques now with how many people it takes and that sort of stuff. So be mindful of those things. We're in the spring, then we're in the summer, and football will pick up at the end of the summer into the fall. So if you guys are doing EMS coverage for football games and that sort of thing, just be mindful of these injuries and these high impact collisions that are happening. As we assess things, external bleeding of the head, injuries, lacerations, abrasions, those types of things that cause external bleeding of the head. What would we expect on external bleeding of the head? A little bit of bleeding, a lot of bleeding?
Depends. A little cut looks like a big bleed, but it's really not a big bleed. It's just blood's getting soaked all in your hair if you have it.
Yeah. So, the head is pretty vascular, the scalp, the face. So it could be a pretty minor cut, but it may produce initially quite a lot of blood. And then you've got the issue of hair. So that all you folks with a lot of hair, if you get a laceration on your scalp, we've got to work our way through that to actually get to the injury and control the bleeding. The bleeding usually is pretty easily controlled, but with some bandages, direct pressure, even if it's a pretty good laceration that's going to require some stitching or staples, the bleeding is usually controlled pretty easily and quickly. But it's just a little bit of work to get through all that to figure out where it is and how bad it is and that sort of thing. So don't try not to freak out with the head injuries. The scalp lacs are like I said, they'll bleed quite a bit, but hopefully it won't last long. You can get some direct pressure on and stop it. You can see the injury and get a good feel for it as to what it's going to need. They've got multiple ways to fix these things now. The stitching they've always had. They're using staples now. They've got glue. So different ways to fix it. Just depends on where it is, how long it is, and the doctor's choice in a lot of cases um, as to which way they go with this. So, but you'll work your way through that. As we keep assessing these folks in the head area, though, we're gonna check. Zach told us we were gonna check for DCAP BTLS, and that's what we're gonna check all the way down the body. We're looking for those types of injuries, and as we palpate the head, people usually start at the top, work their way around the sides, the back, feel down the cervical part of the neck, and then come around to the forehead, the face, and that sort of stuff. Somebody want to talk me through where they're looking and how they're looking for these types of injuries?
You're supposed to look everywhere.
Mm-hmm. You are. So what parts of the head are we looking at, in, through?
Everything.
Everything.
Ears, nose, mouth.
Okay, so ears, she says. What are we looking for?
Fluid.
Spinal fluid out of here.
Okay, spinal fluid. What else?
Any liquid just coming out.
Okay, any liquid. So there's the potential for spinal fluid. There's the potential for blood. So those two are going to be the most important in the ears that we're looking for. Keely said nose. What are we looking for in the nose?
Any deformities, bleeding.
All right. Deformities and bleeding in the nose. What about in the mouth?
They have all their teeth.
And if they don't, are there teeth in the back of their throat?
Okay. So we want to see if their teeth are there. If any are missing, where did they go? Did they swallow them? Were they knocked out on the ground? What else?
Look at the gums.
Okay.
Look around their eyes, make sure, or see if they got any battle signs.
Okay. So look around the eyes. We look for those raccoon eyes, which are bruising that's going to show up around the eye sockets. Battle signs, that's going to be some bruising typically behind the ears. When you're um, looking inside of things, we talked about the eyes and the equalness in the pupils. So we want to check their pupils for equalness and reactivity. Ears, nose, mouth. Again, in the mouth, looking for teeth missing. Also, see if they bit their tongue. If there's any blood in the mouth, we need to try to see if we can figure out where it's coming from. It may not actually be coming from the mouth. It could be coming up from the stomach or esophagus area. So, or it could be coming out of the lungs, and they could be coughing that stuff up. So, blood in the mouth could be different. It could have different avenues for us to go with. So we need to kind of figure out where that's coming from, and then we're going to check on their face here. So checking the face, what does that involve?
Looking and feeling.
Yeah, that's going to be looking. We're looking to see if there's any cuts or bruising or abrasions, swelling, stuff like that. But we're going to need to palpate as well. Their cheek area, so we're going to be palpating under their eyes, on either side of their nose, down their cheeks, under their mouth, on the chin, the jawline, seeing if all that stuff is intact, if there's any kind of discrepancies that may be there as far as bone damage, those depressions, fractures, or crepitus noises from bones rubbing that have been busted up. So those types of things are all what we're looking for on this head assessment. So again, what happened to the folks is kind of going to play into it a bit. And if they had a direct impact with their head or face, when those folks that go face first into the windshield in a car wreck are going to be more inclined to have issues there than somebody that fell out of a tree and landed wrong on their leg or foot or something. So what happens to them is important, but when we start this assessment, these are all of the things that we're looking for in this full-blown trauma checkout. Once we get done with the head and face, we're going to move down the neck. And in the neck area, what kind of things are we looking for with these trauma folks?
Feeling the vertebrae.
Okay, so that's in the back of the neck. We're going to feel down the cervical spine, checking vertebrae. We should be looking for anything that feels abnormal as far as shape, anything protruding out or indented, that type of stuff. Also, if the patients are conscious, that's going to help us out because we can ask them questions, especially when it deals with pain or sensation. The unconscious folks, we won't be able to get responses from, but if they can talk to us and they can help us kind of pinpoint and mark injury sites based on pain. What about in the front of the neck area?
Make sure they ain't busted their trachea up.
Okay, so we're gonna check out the trachea, look at the Adam's apple, those types of things. That stuff should be midline, which is kind of straight down the center. Make sure it's intact, it's good, it's not shifted to one side or the other. What else? What about those major vessels in the neck?
The carotid. Make sure they have a pulse.
Make sure they have a pulse. We're going to check that earlier. What are we going to look for now? What's the other vessel?
Check for JVD.
Yeah. Yeah, check those jugular veins. See if there's any distension in those. If there is, that could indicate some circulation issues for us. That could be related to the trauma in some fashion. If they're starting to have some internal bleeding, they're getting less volume in there. We may not see any distension there, but if things start to back up, if the heart's not pumping well, that blood is starting to pull up, those veins are becoming distended. That could alert us to some other things going on with this trauma patient as far as the circulation is going. So check those vessels, see how they're doing, see what they look like, and check the trachea, make sure everything's intact. Look in the neck area for that DCAP BTLS stuff. If there's any soft tissue injuries, and then we need to deal with those. How would we deal with soft tissue injuries in the neck area if it was a puncture or a stabbing or a gunshot or something like that? What kind of dressings would we put on those injuries in the neck?
You want to use an occlusive dressing?
Yeah, you would want to use occlusive dressings there. Same with the chest and the abdomen. Basically, from the neck to the waist, if we have punctures into the soft tissue and deeper, we're going to go occlusive dressing on those types of wounds in this area. All right. So that gets us through the head, the face, and the neck. Any questions about the assessment part of that area? We're looking for injuries. We're documenting injuries. When you document your injuries, typically the most important thing is what type of injury and where it's located. But in a lot of cases, they want you to be as specific as possible. So try to be very clear and concise about what the injury is. And they want your documentation should include estimated sizes. So if it's a laceration, it should have an approximate length attached with it. If it is like a puncture or a gunshot or some kind of hole in these people, it should have some kind of size attached to it. So be descriptive with these injuries, be accurate with the locations. You can use your big 25-cent words in the medical world to with where it is in the body, anterior, posterior, lateral, medial, all of those descriptive locations we learned in the very beginning of this course. You can use those for descriptive locations with these injuries, but be more detailed about them with links, with sizes of holes, with the description of what the injury is, and then what you did for it, how you bandaged it. If you did bleeding control, then that's a documentable thing. If you did wound care, that's a documentable thing. So make sure that your documentation is accurate and appropriate in these instances when you're dealing with these things. So the thoracic cavity, from an anatomy and physiology standpoint, as we move down the body, when we get to the thoracic cavity, what are the vital organs that we are concerned about in the thoracic cavity?
Lungs, heart.
Lungs, heart.
Stomach.
Anything? What?
Stomach.
Stomach.
Sorry, I'm back, Cliff. What are we talking about?
We're talking about the thoracic cavity and what vital organs we are concerned about that are located in the thoracic cavity. We've got lungs, we've got heart, part of the upper part of the stomach, and then what attaches to the stomach that gets us down from the head down to it. Same with the lungs. We've got the esophagus traveling through this area, and we've got the trachea in this area. So those are the parts. Remember that the diaphragm is at the bottom of the thoracic cavity. That's the border between thoracic and abdominal. So that diaphragm is going to be moving. It contracts and expands. So it has a downward and upward movement, but that is kind of the divide line between those two cavities. So so you have that. What protective structure is in the thoracic cavity?
Rib cage.
Rib cage. All
and
right.
intercostal muscles.
So we've got a rib cage. We've got muscles all around. We've got those organs in there. How many sets of ribs are there? Oh crap! Why are you asking these hard questions?
And like 19 ribs, 20 ribs, somewhere around there.
What? Somebody better get on Google. How many sets of ribs are there?
12.
12. All right, 12 sets of ribs. How many vertebrae are in the thoracic spinal area?
6.
No.
No, it's all your T vertebrae.
How many T's are there?
12.
12. See a correlation here?
12 sets of ribs.
12 sets of ribs, 12 sets of 12 vertebrae in the thoracic region. Um, so this is all wrapped up together, and we typically refer to this area as the chest. So on a patient, this is the chest area, and this would be the upper back area where your shoulder, basically where your shoulder blades are located on the backside. So you come out of the head with your cervical spinal area. You've got your six or seven vertebrae in the cervical spine? 7, I think.
7, I think.
And then you've got your 12 for the thoracic spinal area. You've got your 12 sets of ribs that wrap around the sides and attach in the front to the sternum. And all of that protects the lungs, the heart, the trachea, the esophagus as it goes down to the stomach. And you've got the diaphragm at the bottom, which is going to give us that that upward downward movement to create the negative positive air pressure changes so that we can breathe. So injuries in this area, we have all of the, as we do this assessment, we have all of the DCAP BTLS stuff that we're looking for, but what type of injuries are we looking at potentially having? And then what are we going to do with them? So let's look at injuries first. What type of injuries?
You could have anything really, lacerations, abrasions.
Yep.
Contusions.
Lacerations, abrasions, contusions. Are they going to are they going to cause us much grief with those types of injuries?
What was the question?
In the chest area, the different types of injuries that we have, he's talking about lacerations, abrasions, contusions. Most of that is kind of superficial soft tissue stuff. If we get into penetrating type injuries in the chest area, what potential problems may we face?
Organ damage.
Tension
Okay.
in the thorax.
Organ damage, pneumothoraxes, those,
Some pretty significant bleed.
yeah, significant bleeding. There's a lot of, remember when we did these, when we had those pig hearts, there's some significant vessels in this area and some very large vessels. So this is where all the blood flow could be going away if some of those vessels get damaged to the point where they are lacerated and bleeding into this chest cavity. You could potentially have a lot of blood loss here. So through this cavity, you've got your aorta, you have your large arterial vessels, your large venous vessels, you've got your large pulmonary vessels, and so all of those things are found in this area. So if we get into penetrating injuries, stab wounds, gunshots, if we get into structural injuries with the ribs, if those ribs start to get broken and they start to lacerate these large vessels, we could really get into some bleeding issues, some volume control issues, and that's going to be quite problematic for us. So if we do get into penetrating type injuries, remember that the wound care is occlusive dressing. So we want to do occlusive dressings on these to seal them up. The reason that we're sealing them up, why are we sealing them up?
So no outside air can penetrate inside.
What's the science behind this? What's the reason?
One's like positive pressure, one's a negative pressure, and it's a vacuum.
Yeah. So remember that diaphragm is the deal that makes us breathe. So when it's contracting and relaxing, it's creating that negative pressure and positive pressure atmosphere in there. But if there's an extra hole, when it's trying to pull that negative pressure, it's not going to be able to. So if it's pulling that outside air in through those holes, then we're not going to get that pressure change as effectively, which means the breathing is not going to be as good. So we need to seal these things up so that that pressure change can occur like it should, and then the breathing will work as it should. So if they're full of holes and you don't seal them up, they're probably not going to be breathing very well. So make sure you're doing that. What is a flail chest?
Section of ribs that broken off from the other section. So when the rib cage moves up, they move down.
Okay. So it's an area of ribs, and it's defined as two or more ribs that are broken in two or more places. And so they actually become detached from the rest of the structure. And so what you'll usually have is an opposite movement in that area of what you would expect or what the rest of the area is doing. What is the fix for that?
And it kind of like a like an ace bandage or something just to hold it into place.
Yeah, you just need to technically now you can just apparently you can just wrap it or tape it. We used to use a bulky dressing on it. We would like roll up a blanket or a sheet and put over that section, and then we would tape all that together. The key is to attach the two segments, the two sides back together. So this essentially the middle section is broken out, and then you've got the two sides that are not attached anymore. So we have to span that broken section and get those two sides back together so that they can move together as a unit again. So if you want to do I would be careful about like an ace wrap type of thing, because you don't want to wrap all the way around the person, because then you could restrict the chest rise movement of their ability to inhale and exhale. So lots of tape in this area. Make sure that you're taping from a good section to another good section, and you get all of that broken section they had all kinds of creative things in the past. They would lay like an IV bag of fluids over that area and tape it down. They had the ambulance used to carry little sandbags that they would lay on there and tape down. People started rolling up sheets, get a little roll of a sheet and tape it down. So they had a lot of ways of dealing with that, but the key is the tape, because you gotta connect the sections back together. So there are some injuries that your book talks about, some injuries with the heart. Since we're in this section, they talk about some blunt trauma injuries to the heart. There is a injury that's called a myocardial contusion. Anybody want to take a guess at what that is?
A bruised heart.
A bruised heart. So that's actually a bruise in the heart muscle. So all of that muscle, you guys visualize that heart that you were dissecting a few weeks ago, and that very thick wall of muscle around those ventricles. It would be a traumatic injury that hit that area and caused some bruising in that muscle. So there is an injury that's called commotio cordis. This is typically something that's seen in sporting events. Different types of sporting events have this, but it is an injury where there is a significant blunt force on the chest that impacts the heart. And what it does is the force is so significant and the timing is exact to where when this impact occurs, it actually makes your heart stop beating. The force and the impact with the timing, it actually basically it just wipes out the electrical activity and your heart stops beating.
Is that the R on T phenomenon they talk about?
It is, but it is it occurs just from sheer blunt force. So it's like a straight impact right where the heart is located in the chest. And it can happen with baseball players. Baseball could, when they hit a baseball, it could come and hit them right in the chest, boom, and that perfect timing, and these people just drop dead. I mean, right there, it's like cardiac right there. So, but the or like with the people that are fighting some of this martial arts stuff or MMA junk or things like that, if they take a direct, sometimes they can do it just simply with a punch, a direct punch right into the chest at the heart at that right time with enough force, and it'll just it interrupts the electrical cycle and it just stops the heart. So
What was that called again?
that is commotio cordis is the term for it.
Commotio cordis?
Yep. It's in your book on 872, if you're in your book. And then
Oh.
and you'll see. So obviously, what would the fix be for this?
Chest compressions.
Yeah, we're gonna be in our CPR mode on these folks. So most likely the only external injury that you may see is some bruising or a simple red mark on the chest, on the skin there. You probably won't see any external bleeding. You won't see any um, other injuries unless they sustain something from the fall. But most of these people are upright. They're in an active role, and then they just drop dead. It's like boom, they don't wake up. So think about a baseball pitcher on the mound, pitches the ball, batter hits the ball, comes right back to him, hits him in the chest, and he just drops right there, and he doesn't get up. And that's what this is. That it's just it's really a freak phenomenon, and it's all about the amount of force and timing with the heart rhythm. So um but something for you to be aware of. It is fixable with CPR. We can do our CPR stuff, defibrillation if we get the right rhythm that we're seeing, and get this thing restarted. But it is kind of unusual deal. All right. So our assessment in the chest area is going to deal with, again, we are going to be looking for these DCAP B TLS injuries. We are going to be palpating for the we are trying to feel for deformities and broken bones in the rib cage area and that sort of stuff. And then we are going to be listening. What are we going to be listening for?
Breath sounds.
Okay, breath sounds. What else can we listen for? What's the other noise maker in the chest?
The heart.
The heart. We can listen
Yeah,
to heart sounds. So breath sounds and heart sounds. Remember those heart injuries. We talked about some heart injuries in the medical section, like cardiac tamponade and those types of things. These are also injuries that can be sustained from traumatic events. So again, you could run into some of these same conditions that we talk about on both sides, on the medical side and the trauma side. Cardiac tamponade is one of those things, that's blood leaking into that pericardial sac. So that could happen from a medical event where a vessel just ruptures and starts leaking. Um, or it can happen from a traumatic event where the force caused the vessel to rupture or leak. So you could have those same types of injuries and situations from both medical issues as well as traumatic events. So we want to check all of those things and make sure that they're good to go. So remember those three things. One of those three things in Beck's triads is muffled heart tones. So we want to listen to the heartbeat to make sure that it's a good strong thing and a good clear sound, and that blood is not pooling in that sac and muffling the sound for us. Listening for lung sounds in these traumatic injuries, that can give us some indications for making sure that the lungs are clear, but also making sure that the chest cavity is clear. as if we were in a pneumothorax situation, that air is going to be leaking out into the pleural space. And as more air gets in that space, what's going to happen to our lung sounds? Hmm?
Would they be like decreased and strained?
Okay, so what if one of those lungs has a puncture and it's leaking air every time they inhale, exhale, air is going to leak out into that pleural space. As that pleural space fills up with air, it is going to decrease lung function, which is going to diminish breath sounds. So as breath sounds diminish, typically this will be on one side unless both lungs are injured, and it could be on both sides. So you have to look at these injuries. But as that space fills up, it is going to decrease lung function, and that is going to diminish breath sounds until the point where they become absent because the lung can't function. At that point, we are in the tension pneumothorax arena. So you can have a pneumothorax for a length of time, and that could vary depending on how fast the air is filling that pleural space. So a pneumothorax could be for a while, and it should lead you, if unresolved and the pressure isn't released, it should lead you to a tension pneumothorax at some point. So assessing those lung sounds, if you can hear them now and they're nice and clear, you assess them over time, and over time they start to diminish. You should start to suspect that these people have a tension pneumothorax. So we're going to need to get some relief for them so that that lung can continue to expand and contract and function. All right. Any questions on chest trauma assessment type stuff? That leaves us with the abdominal region. So again, the divide line is the diaphragm, and then we get down into the 4 quadrants of the abdominal region. So just for a quick review, the 4 quadrants of the abdominal region, what major organs or anything of significant do we find in the left upper region? Anyone? Left upper region, what's there?
Spleen.
The spleen?
Yeah.
What else?
Stomach.
Okay. You're on a roll. Keep going.
Part of the liver, the pancreas, and the top part of the colon.
Okay. One more important organ that's there.
Part of the liver and part of the pancreas.
Yeah, part of the liver and pancreas, spleen, stomach, but also the kidney.
Oh.
Yep. So left upper, remember injuries to the left upper. We're having traumatic injuries in the left upper quadrant. The spleen is a target. That's pretty much like an oil filter for the blood. It's a blood reservoir. So it's just an organ that's full of blood. And if that thing gets damaged, obviously it is going to bleed, and it is going to bleed probably, depending on the damage, it could be significant. So in a lot of cases, you'll hear people, if they're going to trauma surgery for the abdomen, if it's on the left side and especially left upper, then probably they've got spleen damage and they're having to have surgery to repair that. But that's a big high value blood target in that left upper area. The liver also, the liver is a large organ, so it spans across both upper quadrants. Um, some in the left, mostly in the right, and also very vascular. A lot of blood going through it. It's filtering a lot of blood, and it will bleed quite a bit. The only organ that regenerates itself, so it can repair and regenerate. But it does have the tendency to bleed. So if there's any kind of laceration to it, you're going to see a lot of blood loss there. Um, not much, not much blood concern loss in the stomach, but if the stomach is perforated or lacerated, then we're looking at more of a sepsis type of issue with the stomach contents, the food particles, the acids that are in there. We're going to have more issues, not necessarily a ton of blood loss issues, but we're going to have probably a lot of sepsis type issues with that. With the stomach and with all the intestines. So intestines throughout all four quadrants, and you're gonna have any obstructions in there, or if you have any perforations or lacerations, there will be a small amount of bleeding, but it's going to be more septic type issues coming. So you're going to see those in those patients. What else is in the right upper? We talked about the liver spanning across both sections. What else would be in the right upper?
Gallbladder.
Gallbladder.
Okay, gallbladder's over there. A little bit of the pancreas is over there. Intestines are over there for sure, and then your other kidney is over there. So you got your right kidney, which is over in the right upper. You've got most of your liver in the right upper, and then the gallbladder is the other issue. that's over there. And so you have those. As far as the two lower quadrants, what are we mostly looking at?
Primarily intestines, but on the right side you have the appendix.
Okay, so primarily it's going to be intestines, large and small, spanned out across this whole area. The appendix is located in the right lower, and then you've got all of the reproductive organs that are located down here, as well as the bladder, which is finishing off that abdominal region and heading downward. So um, most of the bleeding organs are going to be in the upper quadrants. In the lower quadrants, again, you're dealing with mostly the intestinal region, a lot of intestines down there, and then the reproductive organs. So it is possible for a person to lose all of the blood volume in their body in this region. In the abdominal cavity, they can lose all of the blood in the body. They can bleed out internally and be gone with all of that. So watch out for these blunt force injuries. You know, it's easy for us to find external bleeding, but it's not as easy for us to pinpoint internal bleeding, and we certainly can't do anything about internal bleeding. The only way that they're going to have any relief from that is trauma surgery. So they're going to have to go in there and get in there and see where the bleeding actually is and stop it. But we need to look for these signs and symptoms. We need to see the traumatic forces that we can put together to figure out what is possibly affected and impacted, and that should hopefully have some weight on our decisions on the scene. So if we are assessing the abdominal region, how do we assess it? If they are complaining of pain in the left upper region, how would we assess the abdominal area?
Start at the right lower and go towards their complaint area.
Okay, so we start usually at opposite, far away, work towards their complaint area. And how are we assessing? How do we do that?
Palpate, press down.
Okay, so we're going to be palpating, pushing down with force. What are we looking for?
Tenderness, hardness.
Okay. We're looking for a feeling of tenderness or rigidity. We're looking for reactions from the patient. Typically, when you push down on their abdomen, you should kind of look at their face and look at their body reaction. If they tense up or guard a little bit, or these types of things will tell us some keys there. So we're actually touching them. We're pushing downward. We'll see if there's any pain when we push downward. We'll also see let that pressure off. So if we give the direct push down and there's pain, that's tenderness. Let the pressure off and there's pain, then that's rebound tenderness. So make sure that you guys are paying attention to the patient. It's not necessarily that they have to scream and jump off of the stretcher for you to understand that's where it hurts, but they may just, tighten their eyes up a little or put that grimace on their face or something like that, and you'll see that. All right. So again, if there's any external bleeding in the abdominal area, obviously we can't put a tourniquet on it as much as we may like to. So how do we deal with bleeding control in the abdominal region?
Pressure, direct pressure.
Direct pressure. If that's not working, what are we going to do?
Quick clot.
Quick clot, that's an option. What else? Brian, how are you military guys stopping bleeding abdominally if direct pressure isn't doing it?
Hold on. Let me think. It's pretty much just occlusive dressing.
Okay, occlusive dressing. You guys remember that Stop the Bleed campaign that's out now? They are now, if it is a wound, kind of like a puncture type of wound or a hole type of wound in the abdominal region, they're now packing material in there, so you can actually pack into that hole or into that. If it's a deep laceration, you can pack gauze down into it to help block it up and occlude it. Yes, if it's that type of injury, occlusive dressing is going to be the final answer. Quick clot is certainly a good choice. And then once the bleeding is controlled, we always remember that we need to seal it up. But it may be a local protocol thing that you guys have to look at about being able to pack wounds for bleeding control. But the priority for bleeding treatment now is to stop bleeding as quick as possible. And tourniquets are not an option in the chest region or the abdominal region, but wound packing, quick clot, for those agencies that have TXA available, those types of things are going to be choices for them.
Even out at the base, like they won't even let us pack into any of the cavities.
Really?
Like if it's in the chest or in the abdominal cavity.
Yep.
Because they were like, we don't have that. They told us that we don't even have enough gauze to even jam into somebody.
Yeah, you're gonna need a lot of gauze. If it depending on the hole, but if it's typically this is gonna be a big deal, and bleeding control in the abdominal region, in the chest cavity, bleeding control is gonna be difficult.
So they're still on the old direct pressure method.
Yeah, and that ain't gonna stop it, because that's just gonna keep it from coming out, but it's just gonna bleed in. So that's basically keeping the door closed on the house, and the house is filling up with water because the bathtub's running over.
Our what is it? Combat gauze.
Yeah.
Is more for like junctional wounds,
Mm-hmm.
junctional holes.
Yeah, that's right. So it's a big, a big padding thing for absorbing. It's got the straps for tying, so you can put the pressure on it and you can secure it.
We got one of those.
It's not going to stop it.
What are those bandages called? It looks like a big old tampon on one end and the thing that wraps around you on the other end.
Yeah, yeah. But those things are just not going to stop it. They're just going to soak it up and keep it, as the blood keeps coming, they're going to soak it up, but it's not going to it's probably not going to make a difference. If you have the quick clot you can get on there, that may work pretty good. If you had the stuff that was the powder that you could pour in there, that would work better than the stuff that's embedded in the gauze wrap. So, or you can,
That powder worked good, but it also burned the crap out of you too if the wind was blowing.
yeah, it burns. So that's kind of how it does it. It's like a chemical cauterizing type of thing. So that's how it stops the bleeding. But if you get it on you, it's going to burn too. So you got to be careful with that stuff. Most people
I know
now have,
the impregnated quick clot stuff that we have, the combat gauze, it takes 3 minutes
yeah,
direct pressure to actually start a clot.
yeah, and that's a long time to bleed if it's a pretty good bleed. So watch out for those things. It's going to be a difficult challenge to do that. What about eviscerations? If you have these types of injuries, laceration type of injuries where the intestines are coming out of the abdominal region, how do we deal with that? What kind of dressing and wound care are you doing there?
Moist dressing.
Moist dressing on the intestines, and then what?
Dry on top of that.
What type of dry?
Sterile dry.
Sterile dry, but we need to make sure it seals. So I tell you, the best thing is saran wrap if you've got it. Some people actually carry it. I've seen like boxes of little rolls of saran wrap on trucks before, but the best occlusive dressing that there is, it just saran wrap. You can just wrap people up with it. But that's kind of what you need in this type of situation. Moist dressings on the actual intestines to keep them from drying out and dying, and then we need to seal it up so that it stays moist, and we get that occlusive coverage back for the. It helps with infection. It helps with pressure, that sort of stuff. So make sure it gets sealed up. And if it's a large thing, I tell you, saran wrap is great. So if you're at somebody's house, ask them. That's what they're gonna do. They're sitting there with their guts hanging out. You're gonna ask them for some saran wrap. That's gonna be the best way to deal with it. All right. So head, face, neck, chest, abdomen. All right, this is us working our way down the body. What's left? We look at the back, we look at the extremities. These are all the things that we're checking. As we're doing this systematic trauma assessment, we're focused on all of these little injuries. This is where we're going to get all of the stuff so that we can pass it on as we pass on patient care. This is where you've got to get down to the skin. You've got to get these clothes off of these folks so that you can see the skin, you can palpate the skin, you can feel any depressions, deformities, indentions, those types of things, and then you can document and treat as appropriate. This is essentially following that National Registry skill sheet for trauma assessment. So if you guys are familiar with that sheet, this is that focused assessment part of it. And so we're just going right down the body and we're checking all of these important things as we go. Any questions about this section?
Nope.
Nope. All right. Any questions about anything at all?